Good morning, everyone. My name is Deborah Peterson Small. I'm a lawyer and criminal justice and reproductive rights activist. I'm really happy to be here with all of the faculty and students from Meharry who've joined together to discuss an important topic, reproductive justice. I'm happy to be there, if not physically, virtually, and look forward to getting feedback from you all about the things we're going to discuss this morning.
Hi, I'm Lynn Paltrow. I'm the founder and executive director of National Advocates for Pregnant Women. I'm very honored to be here this morning. I'm sorry we can't be there in person, but we look forward to finding a time after where we'll be able to take your questions and hear what you have to say as well.
I am particularly happy to be here speaking with you all from Meharry because of your long history in providing health care and training health professionals, particularly to serve Black communities. And an important part of that has been the services that you've provided for Black women. So we're going to have a lot of our conversation today be focused on the impact of drug policies on communities of color, but particularly on Black women and their reproductive health. First slide. So I'm starting with this one, which may be jarring for some people, but I think it's important to remember that at the very beginning of this country, Black women under the system of chattel slavery were treated like property in the same way that you would deal with a horse or a cow or any other chattel piece of property. This picture, I think, sums up that relationship quite clearly. This woman, for all practical purposes, was there to nurse this baby. Her own particular children, she had no ownership in, but as the property of another, she could be required to use her resources to provide care and sustenance for someone else. And it also represents how the history of this country was built on sucking on the teat of African American women, using our labor and resources. Next slide. As enslaved people, Black women had no control over their own bodies, not only with respect to the labor that they were required to provide, but also their reproductive bodies were not there. They could be required to have sex with people that they didn't want to and bring forth children that they may or may not have wanted. In fact, those children were not considered to be their own. They were merely vessels for bringing forth new property. And as Thomas Jefferson wrote, I consider a woman who brings a child every 2 years as more profitable than the best man on the farm. Next slide. So distinct was the view of the value of women versus their fetuses that it even came into play in punishing people. This photo represents, or rather this image represents a practice that was common during enslavement. If an owner wanted to physically punish a woman who was pregnant in order to avoid potentially harming her fetus and thereby his future property, they would dig a hole in the ground and lie her face forward so that her stomach would go into the ground and she could still be whipped on the back. And as Dorothy Roberts said, it is the most striking metaphor I know for the evils of policies that seek to protect the fetus while disregarding the humanity of the mother. We see the same thing today in places like Texas that have passed laws to provide for fetal health, but don't care about the health of the mother and will not treat conditions like diabetes and other things in pregnant women because their only concern is for the health of the coming baby. Next slide. As part of that narrative and reality was also the belief that somehow Black women didn't have the same types of maternal feelings for their children as other women, and therefore they could be easily separated, either through selling them away, which is what we're seeing here, or other ways in which women were deprived of their children. And that narrative continues today in the way the child welfare system so casually separates mothers from their children, and the ways in which our criminal justice system will easily lock women up for long periods of time without any consideration to the impact that that will have on her and on her children. Next slide. Because we're talking about drug policies, I think it's important to discuss the word addiction and where did it come from? Well, the word addict evolves from the Latin word addictus, which literally means to devote or surrender oneself to something. In ancient Rome, people who were captured in battle were given as slaves to Roman soldiers as a reward for their performance. These people were known as addicts. Eventually, any person who was considered a slave to anything became known as an addict. That understanding survives today to some degree in our understanding of the term addiction, which has been defined as a persistent, compulsive use of a substance or involvement in activity that is known by the user to be physically, psychologically, economically, or socially harmful. Another way of saying that is that the person who is addicted is enslaved to that substance or activity. Next slide. In talking about the roots of drug prohibition in the United States, I think it's important to remember that a little over 100 years ago, all the drugs that are currently illegal were actually legal and commonly used in over-the-counter drugs and in things that people could order through the mail. So this ad, as you see, is one for cocaine toothache drops, which was quite popular at the time and easily accessible and relatively cheap at 15 cents. And I think all of us are familiar with Bayer products, but I think most of us don't know that one of the products that Bayer regularly manufactured and distributed was heroin, and it was considered to be a cough suppressant. And so in this ad, you see a mother about to give her child a spoonful of a tonic that was full of heroin, which was believed to suppress coughs. And so early addiction in America was, as is often is today, the result of pharmaceuticals that people were either prescribed or given to treat a variety of problems and maladies. Next slide. But over time, we shifted from seeing these drugs as relatively harmless things that could be consumed to address particular problems to things that actually represented fear of the other, particularly people of color. Let's play this video clip.
Looking to find out more about the longer history of drugs in America, I found an unlikely source in Lincoln historian Richard Miller. His research put drug laws in a fascinating historical context.
Historically, anti-drug laws have always been associated with race. In the 1800s, certain kinds of drugs that are illicit today were common in this country. Cocaine was widely used, heroin. People used drugs. It was something that was just ordinarily accepted. Opium, for example, was used by middle-aged, successful whites, often housewives in the South. If people were addicted or abusing drugs, they were viewed sympathetically as people who had to be helped. It was seen as a public health issue rather than a crime issue. But one of the first changes was on the West Coast, when smoking opium was made a criminal offense. Now, why would opium smoking be illegal in California but not in Mississippi? What was going on in California that was a concern about smoking opium? Well, as it turns out, it had nothing to do with opium itself. The concern was with the people associated with smoking opium, and that was the Chinese who had come to this country, and many of whom were in California, working hard, working for very little pay, and becoming part of the American success story. But their success was taking jobs away from white workers. So politicians got together and decided they got to find something about the Chinese for which they can be criminalized to get them out of the way. Now, of course, you can't throw people in jail simply because they're Chinese, but you can throw them in jail because they smoke opium. In the same way, we saw things going on with cocaine. Again, it was middle-aged, successful people in this country, business executives, physicians, housewives, all perfectly legal. But then around the turn of the century, cocaine began being associated with blacks. They could withstand police bullets, it was thought. They can work hard all day, all night long, and all day long again, threatening the jobs of white workers. And so laws began to be passed against cocaine. You're not arresting these people officially because they're black. You're arresting them because they've committed some sort of drug violation. Next, of course, we see the change in reputation that hemp has had. Hemp was a legitimate crop from colonial times forward. a widely appreciated commercial product. But then in the 1930s, hemp changed into something vicious and fearsome called marijuana, because at that time, marijuana smoking was being associated with Mexicans, working hard, working cheap. And once again, what was being outlawed was not being Mexican, but just some habit associated with Mexicans. These laws set up a very dangerous precedent of racial control.
It seemed that time and again, drug laws targeted any immigrant group seen as a threat to the established economic order. But how then did Black Americans, who came to this country over 200 years ago, become the primary target of drug laws in the modern era?
Well, the way to think about African American history in the 20th century is as an immigrant story. I mean, the transition from the rural to the urban, it's one of the great mass migrations in the history of the world.
When Blacks came out of slavery, they were heavily concentrated in the South in farming type jobs. As industries were expanding in the North, Blacks were recruited to come to work in factories. This gave rise to the great migration of Blacks flowing into urban areas.
Before she came to work for my family, Nanny Jeter had joined the wave of Black Americans who'd moved north during the Great Migration. She took me down to her childhood home in Southern Virginia.
We grew up rolling through the woods with a beautiful outside life. The old Victoria would play and somebody would square dance, and it was a completely different world. I love life in the South.
Now, in that environment that seems so wonderful in the South, why did you ever decide you wanted to leave the South?
I left the South because I had to. Jim Crow, during that time, you couldn't, Black people, if they was raped, they couldn't say they was raped. So you never hear of rape. Only the white lady got raped, but the Black woman, I was innocent, but people didn't think I was innocent. No one knew I was leaving. I wanted to bring my children up different. North was the way out. I thought it would make a big difference.
Nanny had never spoken so openly about her past and what it was that had compelled her north. But as I learned more about her life, I began to see the deeper roots of the drug war for Black American families like Nanny's.
Sadly, what many of these families came to find is that they had not really escaped Jim Crow at all, but found themselves in a new system of racial control, a new Jim Crow. Racially discriminatory laws across America ensured that poor people of color migrating from the South would be confined to certain parts of the city that we now think of as ghettos.
Very few people know this, but if you go back and you look at how African-American housing patterns were established in the 30s and 40s, even as a result of the New Deal, the FHA, which was a Democratic New Deal program to inspire home ownership in the midst of the Depression, did more to create ghettos than any other federal program before or since. Why? Because when they were creating the culture of home ownership in America, they were exclusionary to Black people. They put them in the areas that were maybe a little bit economically depressed and subject to heavy rentership. And then they redlined those areas and they would not write FHA mortgages in those neighborhoods. Once those areas were redlined, that was basically a design for a ghetto.
In 1950, people in these neighborhoods were poor, but they had jobs. By 1960, we're talking about the jobless poor because industries had moved out of the inner city, leaving behind concentrated populations of poor people, vulnerable to drug trafficking and all of the other problems associated with joblessness.
And what happens when groups are denied access to the core economic engines in a society? They create their own out of prohibited economies. That was true of the Italians and the Irish and the Jews and everybody else who came to the cities a generation before African Americans arrived.
So as we see in the previous video, the current drug prohibition is rooted in racism. The drugs that we've chosen to make illegal were directly linked to minority groups. And so it's not surprising that our system should end up looking the way it does today. But in looking at women, I think it's important to remember that in the very earliest days of prohibition, the view of women, particularly white women who used drugs, was a lot more sympathetic. So here we find photos from the mid-19th, early 20th century showing women's drug use. But you can see that even though the women are using these substances, and these women are not poor women, that they're not necessarily, there's no police around, there's no punitive aspect, there's nothing about these photos that would make you believe that these are people who were outcast or deserving of punishment. But a few decades later, the view is changed completely. Next slide. Here, by the 1950s and 60s, the US conversation about drugs was heavily racialized. And when it came to Black women, it was also very much linked to the debate about social programs. So the first photo shows a Black woman in the 1950s being examined for needle marks on her arm. It's not surprising that the people who are doing it are local police detectives looking for a reason to lock her up. From the very earliest days, the Bureau of Narcotic Control was obsessed with finding drug-related criminality in Black communities. By the 1960s, the conversation about drug use was also linked to the public debate about people who were called welfare, stereotyped as welfare queens. And of course, the typical welfare queen was a Black woman with multiple children, unmarried, and living in poverty. And this view of Black women viewed them as people who were unwilling to work, not responsible parents, unwilling to better themselves, and therefore in need of state monitoring and supervision of their lives and reproductive choices. That view is still with us today. In fact, we hear it in a lot of the rhetoric we hear coming out of Washington today. Next slide. Which brings us to the role of drug prohibition in fueling incarceration. Currently in Tennessee, Tennessee's incarceration rate grew over 68% between 1991 and 2018. It still remains one of the top states in terms of rates of incarceration. And while the situation has gotten somewhat better over the last few years, Black people, Black men and women are disproportionately represented in the state's prison and jail population. But one thing to note that's relevant to the conversation that we're having today is that currently in Tennessee, the fastest growing segment of the state and local prison population is made up of white women. And many of those women have been incarcerated for drug-related offenses. I'm now going to turn it over to Lynn, who's going to talk more about how this happened to occur.
So, you know, that you've seen this, this history beautifully described by Deborah. And how did the war on drugs become a mechanism specifically for policing pregnancy? And that really occurred in the late 80s and early 90s when we had the alarm about so-called crack babies. This is just one example of thousands of media stories during the early 90s. Time magazine, crack kids, their mothers use drugs, and now it's the children who suffer. You get to the table of contents and it says, can the innocent legacies of drug use be rescued? So if you have somebody who's innocent, you've also got to have somebody who's guilty. So that's one of the narratives that's front and center. And then you get to the story itself and its innocent victims damaged by the drugs their mothers took. Crack kids will face social and educational hurdles and must count on society's compassion. And the story really leads with these children are going to be in schools with your white middle class kids. They're going to take resources away. But what should be obvious is as the story gets to more detailed, the skin color of the child gets darker. You also had stories like this in Rolling Stone magazine, Children's End, babies born to crack addicted mothers are like no others. They're brain damaged in ways yet unknown. And they were yet unknown because they didn't exist. They are oblivious to any affection. How do you care for a baby who hates to be held? Well, this was basically medically insane. If you read the Time magazine article carefully enough and you read down to the 10th column, Barry Zuckerman at the University of Boston Medical School said, we don't really think there is such a thing as crack babies. What we're seeing is poverty babies. This was the starting to be showing the effects of Reagan era budget cuts in housing and in healthcare. But the willingness, why would anyone believe that there were a group of women who would take a drug knowing how it would harm their children? And it really is the legacy of the slides you saw earlier, all the way from slavery, trying to convince white people, Black mothers don't care about their children, it's okay to take their children away and sell them into slavery away from them. If these stories had been about some drug that white women took that immediately caused brain damage, none of the reporters would have just accepted that without looking more carefully. And much of this came from, was instigated by a Dr. Ira Chasnoff, who did a study, I think, of 24 or 26 babies, and ran with this claim of a unique set of harms. You had stories like the one on the left, crack babies, the worst threat is mom herself. And that was also from that period of time. And it's a narrative that's still being used, which is we don't want to focus on the social determinants that actually have the greatest impact. We want to place blame for all health problems on individuals, and particularly if they're low income, if they're Black. And the particular impact of the war on drugs on pregnancy combined the mythology of the war on drugs, that certain drugs were uniquely harmful, deserving of punishment, certain groups of people use them, they deserve to be punished, with the anti-abortion rhetoric of so-called rights for fetuses. And so you can see these two messages. One's about so-called crack babies and the war on drugs and pregnancy. And then you have the ad that was put up particularly in Black neighborhoods. The most dangerous place for an African American is in the womb. And this was by an anti-abortion organization. So it's not our government, it's not the lack of healthcare, it's not the legacy of slavery. It is individual mothers themselves, and particularly if they're Black. So all of this is happening when research is coming out saying, wait a minute, there actually is nothing we can find about cocaine that is causing specific, unique damages. It's not healthy to use it, but it's not healthy in the same way cigarettes aren't healthy, which means there's a risk of harm, but not necessarily any harm, and certainly not any specific predictable harm. We don't have time to show you this video, but we hope you will watch it. It really takes you through the mythology and how it got created and how it's being replicated now, now that opioids are the focus of the issue. If you are skeptical, as many people, including doctors and medical students are about the research, the New York Times did a series on women's rights. One of the stories was slandering the unborn. The author won a Pulitzer Prize for it. And basically it was an apology from the New York Times for contributing to the mythology that led to what I'm about to talk about, which are all these punitive actions. Before I get to that, I do want to say that none of the criminalized drugs are good at causing stillbirths, and none of them cause birth defects. And that's true for the opioids, the amphetamines, marijuana, none of them. And just to point out that there are medications that are very good at safely and effecting ending pregnancy, misoprostol and mifepristone. You can learn more about these, but none of the criminalized drugs pose unique threats to pregnancy, although when pregnancies go wrong, it is often blamed on any evidence of drug use that there might be. So what did all of that media hype result in? We did a study of arrests and forced interventions on pregnant women in the United States from 1973 to 2005. And what we found, we were able to document 413 cases in 44 states in which arrests would not have occurred but for pregnancy. Most of those cases involved pregnancy and an allegation of the use of drugs, and most often cocaine. But there were a wide variety of other reasons that women were arrested: attempted abortions, falling down a flight of stairs, having a home birth. The ideology that the drug war justified, let's be able to lock up women who are pregnant and use drugs creates precedent, the legal authority to lock up pregnant women for anything believed to risk harm to developing fetuses. What we found is that 72% of the targets of arrest were low-income women, 52%, extraordinarily disproportionate, consistent with arrest rates overall, were of African-American mothers. And these are just a few of them, including Kimberly Hardy in the middle here, who knew she had a problem with drugs, left Michigan, went home to Mississippi to get away from the people that were, the community she was in where drug use was high, lost her Medicaid coverage by going back to Mississippi, ended up back in Michigan, did the best she could. But when she gave birth, the baby, perfectly healthy, beautiful baby, tested positive and she was arrested. Deborah, why don't you talk a little bit about what the implications of that are?
So I want to remind people of one of the first slides that we saw, which was an image depicting an enslaved Black woman being beaten with her stomach in the ground, with the idea that that would protect her baby from the physical pain that was being inflicted on her. I would assert that the new hole in the ground is a cage. We lock up Black mothers and poor mothers in order to protect the unborn. But we have to ask ourselves, who's caused more harm to Black children? Their mothers or the white men who gun them down in the name of public safety, wearing police uniforms, or the system of institutionalized racism in which not a single state provides benefits to a mother and children that would have them meet the poverty level. Not one state, and yet every state is willing to spend twice as much money to keep a woman locked up behind bars for drug use.
And as we're talking about white supremacy and how these mechanisms, the arrests, the targeting, promote that, it's simultaneously promoting male supremacy. Because if claims of health or rights of fertilized eggs, embryos, and fetuses ultimately is fully recognized under the law, then that becomes the basis for surveillance and control of all the people, including anybody who identifies as a cisgender woman or not, gives the state reason to control and take away the civil rights of the people of women because of the capacity for or actual pregnancy. So how do these arrests come about? I'm sorry to say that we discovered from the information we had available that in 112 cases, the disclosure of information to the police or other state authorities that led to the arrest, detention, or forced intervention were by healthcare or other helping professionals in medical settings. And in some cases, some states, the majority of cases came from just one or a few hospitals, such as the Medical University of South Carolina. And nearly half of all Black women who were reported to the police or other authorities in our research were by healthcare providers, compared to less than 1/3 of white women. So what you are going to have as you go through medical school, a lot of opportunities to make choices about how you treat people and to what extent you're going to facilitate punitive systems. One of the things that you will probably be told is your obligation, requirement to report to child welfare authorities in certain situations. These are pictures of some of the women we've worked with who've had drug issues, gave birth, and lost custody of their children, including the woman to the far right, for being in methadone treatment, which is the gold standard of treatment for opioid dependencies for everyone, including pregnant women. And yet our system of punishment interpreted her appropriate drug use as a reason to separate her from her child. So I think, among other things, you have an obligation to learn. This is a new report from the Movement for Family Power. Whatever they do, I'm here to comfort her. How the child welfare system across the country has become ground zero for the war on drugs. So in terms of those connections, I urge you to get a hold of that and to talk about it. Very few people know what happens when you refer to child welfare. I think we're all led to believe that this is a system that's designed to help families and protect children. But in fact, our child welfare system is as broken as our criminal law system. They are funded really to do one thing, and that is take children away. The money goes into the foster care system. It does not go to provide housing or food or health care or anything else that people need to keep their families together. There is also no constitutional right to have a lawyer at early stages of child welfare proceedings. Some states do provide it, but from a federal constitutional perspective, there is no such right. Okay, what can you do? Among the things you can do are responsible research. And what do I mean by that? In May 2012, Stephen Patrick, who's now at Vanderbilt in your neighborhood, had this study published in JAMA, a fabulous peer-reviewed study. But the study itself did not account for the political and social environment it would be reaching. And responsible research requires you to think about, if you are presenting data on topics like drug use and pregnancy, how are the legislators and the people who can make great hay out of attacking particular groups of people like pregnant people, how will they use it? This study purported to show a huge increase in neonatal abstinence syndrome, a transitory, treatable set of symptoms for newborns who were prenatally exposed to opioids, including the gold standard of care for opioid dependency, methadone and buprenorphine. The study didn't determine what mechanisms were used to diagnose NAS. Did they just say it was NAS if there was a positive tox? It didn't determine to what extent increases in NAS might have been the result of something positive, more women accessing medication treatments. It didn't determine if the care provided to newborns was necessary or medically appropriate. Typically, newborns are whisked away from the mom, sometimes put in the most expensive place possible, the NICU, when research then and since then shows over and over again the best intervention is to keep mothers and babies together with skin-to-skin contact. It reduces symptoms and often makes any kind of medication response for the baby unnecessary. And the study used horribly stigmatizing and medically baseless terms such as drug-addicted newborn. There is no such thing. Addiction is a set of behaviors, as you heard. Newborns don't have a set of behaviors. They may have a withdrawal sequence for opioids in particular, but they are wrongly stigmatized and called drug addicted. What did that article do? It led to national coverage of alarm, most of which was a little less hateful than the reporting on the so-called crack baby myth, but alarmist new victims. You had Brian Williams on NBC reasserting the crack baby myth, even though every other group had said we recognize that turned out to be a myth. He described it, he said it existed, and now we have opioid babies. And it led, in particular in your state of Tennessee, to the passage of the fetal assault law. On the Senate floor, it was referred to as the neonatal abstinence syndrome legislation. And the claim was, we have this incredibly increasing rate of babies with NIS. It's very costly. We're going to use the threat of arrest to get women to go into treatment. There's a kind of problem with that. Because first of all, although the law claimed to be focused on opioids, which are the only criminalized drugs that have a withdrawal sequence, the law wasn't actually just limited to opioids. It also made any act or omission by a pregnant woman that was not lawful a crime against the embryo or fetus inside of her. So it was passed as drug legislation used as mechanisms for control over pregnant people. For example, the first woman who was arrested and charged with assault, fetal assault, for using drugs had used methamphetamine. which is not the drug described in the legislation. The legislation said opioids if they harm the baby. So from the very first arrest, there was no actual following that law. It was used to arrest a woman who attempted an abortion with a coat hanger. And another woman who was trying to evade the police. She was fleeing in her car, was pregnant during that flight. And when they finally caught her and arrested her, they also charged her with fetal assault because they said driving at those speeds and away from the police was dangerous to the fetus. The other thing that was pretty telling about the law is that it claimed that if you got treatment, you'd have an affirmative defense. But the treatment, the primary treatment for having an opioid dependency is methadone and buprenorphine. Methadone until July of this year was not covered by Tennessee Healthcare. And it's to the extent it's supposed to be funded now, there is very limited access to it. And the way the law was written, it also said that if you completed treatment, you would have an affirmative defense, but you don't complete methadone treatment. You stay on it for as long as it works for you, just like you don't complete diabetes treatment. You don't take people off of insulin when they don't follow the orders, when they cheat, when they drink alcohol or have too much cake. There isn't a completion. It is a maintenance therapy that when it works should be continued for as long as the person wants it to be continued. So what else can you do? Informed, compassionate care. You really have a choice in how you think about these things. I have to tell you that your job isn't to get a particular patient you see to suddenly be able to be abstinent, any more than it's your job to suddenly get somebody to be able to lose weight or, again, overcome a dependency on insulin. You also have a choice about how you think about the people who come to you for help. You can take this approach. You can focus on the individual, like those slides we showed you earlier. Focus on a healthy pregnancy, a lifestyle or individual approach. Don't smoke, don't drink. You get the idea. Or you can focus on staying healthy that acknowledges the reality that your patients live with. Don't be poor, don't have poor parents, don't live in a poor neighborhood. Try not to be part of a racially or socially marginalized group. It is only by looking at social determinants and helping your patients see that it's not all on them. Those people feel it's all on them. And any pregnant woman who has anything go wrong with her pregnancy believes it's something she did wrong. In order to address, for example, the extraordinarily high rates of Black maternal mortality and the disproportionate rates of Black maternal mortality, depends on addressing social determinants. And both you as physicians and your patients as activists can play a role in getting us to take responsibility for all of the things going on around us, not just for changing individuals. We hope that you will give care consistent with ethical guidelines. For example, the AMA Code of Medical Ethics say that you have to respect the law, but you also have to recognize a responsibility to seek changes when those legal requirements are contrary to the interests of your patients. And laws regarding pregnant people and drug use, whether they're the criminal laws or the civil child reporting laws, are very counterproductive. Similarly, the ACOG Committee for Underserved Women says you have an obligation to address and challenge mandated reporting laws because threats of arrest, threats of loss of custody of children have been shown over and over and over again to deter women from getting health care and from speaking honestly with you. And you want them to be able to trust that what they say will lead them to health care, not jail, not loss of custody of their children. In fact, I'm happy to say that Stephen Patrick, the author of the article that we talked about earlier, began after the law passed to really speak out against it. There was such an outcry when it was proposed that it had a sunset provision in it, which is very rare for criminal laws. It said, we're going to put this into effect for 2 years. If it isn't formally reenacted, it will go out of effect. And there's an enormous amount of excellent research. Here are the sources if you want to find them, if you want to do some research on it yourself, about what happened when this law went into effect. What they found was women stopped coming for healthcare. They went over the border to deliver elsewhere. They delivered outside of hospital settings, even when that wasn't really what they wanted to do. And it was doctors speaking out against it that had a great deal to do with the law sunsetting. There have been attempts to reintroduce it several times already since 2016. And you can play an important role through testifying, through writing letters, through doing research, in speaking out against these kinds of total misuses of the criminal law system and the civil child welfare system. Just to give you an example, Deborah found this brochure from Tennessee, and it is problematic on so many levels. First of all, if you look at Born Drug Free, that's an ideology that is presumably supposed to be about certain drugs. But if the gold standard of treatment for opioid dependency is methadone and buprenorphine, you're telling women not to get the medication that can help them and their babies. So it's a very counterproductive message. And you'll notice in the bottom left-hand column, it mentions the Tennessee fetal assault law sunset. Hopefully people know what that means. And they refer to what the Safe Harbor Act, which was intended, I think it was well intended to say, if you get addiction treatment by your 20th week of pregnancy, you won't lose custody of your child. But it's, again, an absurdity in a state where you can't necessarily access methadone treatment, which, by the way, you have to go every day to the clinic to get. If you can't afford it. There is more coverage because TennCare now does cover methadone, and there is more mandate for Medicaid coverage, but there are many, many, many people in the state of Tennessee who are not covered by any health care. So the idea that you will lose custody of your child is your choice is just more than cruel, and a deliberate part of making public health issues the problems of individuals when they are collective problems that we have to address together. We hear some things that, more specific things we can work to ensure science, not stigma, healthcare, not handcuffs. We want to remove the barriers to drug treatment for everyone. There's kind of always this impulse to say, okay, we'll fix this by making it a priority for pregnant women, but pregnant women are in relationships. If the pregnant woman can get methadone treatment or some kind of health care, and her husband, her boyfriend, her kid can't, she's going to split that medication with them. She's going to do whatever she can to include them. So we need to include everyone. We should make sure that all prenatal care providers are authorized to prescribe buprenorphine. There should be big signs in any prenatal care setting that says, if you're opioid dependent or any other kind of dependent, effective non-judgmental treatment is available. That's for the opioids, because you can do methadone and buprenorphine. The other drugs to which people are sometimes dependent on, we don't have very good treatments except to say stop having that dependency problem. If you don't have to test, don't test or report if you don't have to. And if you do report, do so responsibly. If you are required first of all, if you really are seeing behaviors that are threatening or harming children, of course you must report. But if you're seeing a positive drug test and you're not seeing threats to children and you're seeing good parenting and you have to report or feel you have to report, please take the time to give the person you're reporting to all the information. They have to take it down. It makes a big difference if you say, this is a really wonderful mother, there's a support system in place, everything else, but I'm reporting because I have to. I don't think this shows neglect or abuse of any kind. I urge you, and I urge your medical school, to make observation of child welfare proceedings mandatory. To go see it and watch it with parent defense attorneys, so you're not confused about what's likely to happen once you make that report. Even if it's internal to your social workers, they also don't necessarily understand what happens. Provide interventions that preserve the parent-infant dyad. Use the information available from places like the National Perinatal Association. keep mothers and babies together. Independently investigate, find resources and allies. Your hospital counsel is not the only person you should consult with. If you're unsure, go outside, find groups that specialize in the issues. The Harm Reduction Coalition has a new booklet, Pregnancy and Substance Use, a Harm Reduction Toolkit. You can access it online. We, with the Birth Rights Bar Association, have this guide that's about birth in general that you might find helpful and help you to be as compassionate and respectful a care provider as possible. Read. I know you're overwhelmed and maybe you're taking all your classes by Zoom and you're exhausted, but when you can, these are some of the wonderfully well-written books that you should be reading to understand the political, legal, and social context you're in and the role of the war on drugs. And be brave. Think about what civil disobedience you might have to do and might be willing to do. And what will you be willing to do to change a culture if you're in a hospital or someplace that's focused on punishment? What I can tell you is that every hospital that does the right thing has had one, often just one staff person who persisted in bringing the evidence-based research, the best policies, the best approaches to whatever decision makers there were over and over and over again. And though it sometimes took years, those are places where children aren't being separated from their mothers at birth. They aren't being put in NICUs unnecessarily. Women aren't being shamed for being human while pregnant. And there may be even more in it. You might remember there was a big news story about a woman named Nurse Wubbles. There was a person who came in severely injured, and police entered the room and insisted that they be able to interrupt care for this injured person to take blood to test for, I think, drugs and alcohol. She refused to let them in and she was arrested. Her refusal resulted in a $500,000 settlement. I can't guarantee that'll happen to you if you're brave, but I wanted to give you a positive example to leave with. So you may be all that stands between your pregnant patients and the police. And I thank you in advance for really anticipating what the problems might be, trying to find the support you need to do the right thing, and doing the right thing. And remember from Young Women United that we are all more than the one thing that seems to get the most attention or the worst thing about us. People you see love their children, want to do the right thing, and very often are living in the context of a history and social determinants that make that very hard. Thank you.
Can I add something?
Absolutely.
So I just want to remind people of the slide very early on about the woman who left Virginia to move north seeking a better life for herself and her children, and the fact that she had been a victim of rape. All the evidence shows us that the majority of women who have substance abuse and addiction problems are survivors of trauma, sexual abuse, physical abuse, psychological abuse. These are people who are in need of help in our care. As healthcare providers, you want to make sure that you're not adding to the trauma that they've already experienced by putting them in fear of losing their child. We also want to remember that when this happens, very few of those children end up in better circumstances than they would have been in with their mothers, especially if they're children of color. So what we have is a system that punishes women who've already been victimized by victimizing them and their children further. That's not the essence of healthcare, and it certainly doesn't meet the standard of do no harm. So we want you to think about all of those things when you go forward in your work. And I trust and know that you will. Thank you.